Bronchial asthma. Okay, bronchial asthma is a chronic inflammatory process, very important, where we have infiltration with a family of cytokines in the airways. The cornerstone is having recurrent episodes of cough, wheeze, dyspnea, and exercise intolerance, maybe chest tightness. In between, child is completely normal. There is no single cause. Interaction between genetic and environmental factors usually the cause. That can be inherited as a multifactorial trait. Asthma can be atopic or non-atopic. By atopy, we mean immune response to exposure to certain triggers by increase the production of IgE antibodies. On re-exposure to certain trigger, the IgE bind the mast cell and undergo degranulation of mast cell, releasing large amounts of histamine and other inflammatory cytokines, resulting in attacks of the disease. So asthma-related traits include atopic dermatitis and also others like allergic rhinitis, like conjunctivitis, maybe even food allergy, and eczema. So can be atopic or non-atopic. We have chronic inflammation in the airway associated with airway narrowing, mucus secretion, mucosal edema, and the characteristic hyperreactivity of the bronchi to certain triggers with reversible bronchospasm, very important. Okay, so having bronchial hyperreactivity associated with inflammation that is chronic, with narrowing of airways that is chronic, with episodic mucus secretion and mucosal edema cause more and more narrowing of the airway, and the bronchospasm. Very important, this bronchospasm is reversible on the use of bronchodilator therapy. Very important, but on the long run, with chronic inflammatory process that is not treated properly with anti-inflammatory medication, will result in remodeling of the airway walls, ending by COPD or chronic obstructive pulmonary disease that is no longer responsive to bronchodilator therapy. One hypothesis in the pathogenesis of asthma is called the hygiene hypothesis, that suggests that exposure to pathogens early in life protect against the development of asthma by maturation of the immune system, evidenced by low incidence of asthma in children with older siblings. Okay, which mean more exposure to infections, or raised on farms also, which means more exposure to pathogens. Triggers of asthma, many triggers can be found, and very common. We cannot identify certain trigger for asthma episodes, but suggested triggers include respiratory infections, viral infection, one of the most common triggers for asthma attacks. Other include allergens like household inhalants like animal dander, house dust mites, and seasonal allergens including pollens and the grass. Irritants like tobacco smoke, very important to ask about smoking or exposure to tobacco smoke in the house. Cold air, very important trigger for wheeze and asthma attacks. Weather changes, exercise, sometimes asthma and manifestations of chest tightness and breathlessness manifest only on exercise. We have exercise variant of asthma. We have completely healthy life, but on exercise we have cough, we have wheeze, and so on. Emotional factors can play a role. Gastroesophageal reflux may increase airway reactivity. It accompanies asthma to have reflux, okay, or sometimes it can be an alternative diagnosis for asthma if chest symptoms is not responsive to the bronchodilator therapy and treatment of asthma, we should exclude as reflux as an alternative diagnosis. Allergic rhinitis or sinusitis that usually accompany asthma as a part of atopic phenotype, if present, can aggravate asthma episodes. Treatment of asthma should include treatment of comorbidities like rhinitis and sinusitis. Diagnosis of asthma is a clinical one, starting with history, having a history of recurrent episodes of cough, dyspnea, wheeze, chest tightness, exercise intolerance. Sometimes cough is the only symptom, It's called the cough variant asthma. That can be exercise induced or can be nocturnal, presenting only at night. These are variants of asthma and should raise suspicion of asthmatic pathology, necessitating use of anti-asthma medication. Other atopic features, when present in the individual, like rhinitis, like eczema, like food allergy, okay, all these should raise suspicion of asthma. Also, having family history of atopy in the parents or siblings supports the diagnosis of asthma. Ask about seasonal or circadian variation in symptoms, very important. Having symptoms more at night or in the dawn is characteristic. Also, having symptoms seasonal with pollens, for example, support the diagnosis. Ask about the presence of pets in the home. Sometimes it is a trigger. And parental smoking, very important, okay, to cut this habit if suspecting asthmatic process. On examination, if the child is coming to you in between attacks, examination can be completely normal, or in case of long-standing conditions that is not properly treated, hyperinflation can be present with even Harrison sulcus can be seen in those patients who are not well controlled. Harrison sulcus, this groove here above the costal margin at site of insertion of the diaphragm, due to the prolonged use of diaphragm in the respiratory efforts, Harrison sulcus can present as a marker for chronic severe case. On auscultation, prolonged expiration is a hallmark, okay, and expiratory wheeze, prolongation of expiratory phase, very, very, very important. Clubbing is a not feature of bronchial asthma. It's not suppurative condition. If present, think of another diagnosis. Episodes of asthma can be mild, moderate, or severe with varying grades of respiratory distress and hypoxemia. Okay, so can present with just cough, some dyspnea, breathlessness on exercise, up to presenting with cyanosis and all grades of respiratory distress, including retractions and the grunting and so on. Differential diagnosis of bronchial asthma is differential diagnosis of any chronic chesty symptoms. Someone presenting with recurrent episodes of cough, of breathlessness, of dyspnea, of chest tightness, how to think, okay? So think of upper airway disease, sometimes chronic rhinitis, sinusitis, and the post-nasal drip associated with sinusitis is the trigger for the chronic cough and the chronic chest symptoms present. Treat them first before diagnosis of asthma. Also, recurrent episodes of viral associated wheeze can be present, especially in infants with immature immune system. Recurrent exposure to viral infections presenting with recurrent wheezy chest can be diagnosed. They are transient wheezer and not asthmatic indeed. Reflux should be excluded. May we have H-shaped tracheoesophageal fistula. We may have reflux due to immature esophageal sphincter. That is the cause for recurrent cough or recurrent wheeze and chest infections. Congenital anomalies like bronchial cysts, whips, vascular rings, H-shaped fistula, and bronchomalacia can be cause for these chronic symptoms rather than bronchial asthma. Cystic fibrosis, primary ciliary dyskinesia, and immune deficiency also can be the underlying etiology for chronic chest symptoms. Pulmonary tuberculosis should be considered, especially in case with history of contact or being debilitated or immune compromised for any cause. Bronchial compression by lymph nodes can give us a characteristic wheeze of airway obstruction. Pulmonary congestion is in case of left heart disease or any congenital heart disease associated with pulmonary congestion. Congestion of the airway walls will give us wheeze and the chronic chest symptoms. In other words, we can say what is the differential diagnosis of wheezy chest. Wheezy chest can be viral episodic wheeze triggered by recurrent viral infections, can be asthma, is long-standing chronic condition. Can be recurrent anaphylaxis due to food allergy, and anaphylaxis associated with edema of the mucosa and the submucosa, and in case of bronchial wall affection will manifest by wheezing. Also, chronic aspiration for whatever cause can result in chronic wheezing. Cystic fibrosis, it is disease of all tubules in the body, including the airways, presenting with airway obstruction and wheezing. Bronchopulmonary dysplasia also can be the presentation. Bronchiolitis obliterans and tracheobronchomalacia, all these can present with wheeze. So for a child presenting to your clinic with wheezing, you should think of differential diagnosis. Viral episodic wheeze is by far the most common cause in preschool children and infants. Okay, it is high incidence on exposure to viral infection due to smaller airways already, and the apparent or immature immune response to viral infections. So any edema and inflammation of airway will give you wheeze. This can occur on recurrent basis due to the recurrent infections. These episodes usually coincide with viral upper respiratory tract infection, very common in infant presenting with dry cough, with rhinorrhea, congestion, conjunctival injection, and then develop wheeze. This is viral induced wheeze. Not necessary to have a family history of asthma or allergy, but usually we have family history of early viral wheezer in other siblings. It is more common in males due to narrower airways and usually resolve by 5 years of age, and it's not a permanent asthma. The other important differential is atopic asthma. Okay, so we have these recurrent chest symptoms due to asthma. Okay, when we have recurrent wheezing that have multiple triggers, viral infection or inhaled allergen or house dust mites or pollens or bits, having multiple trigger factors rather than only viral infection suggests that we have asthma. Having a family history in the siblings or parents suggests and the family history of asthma or any other atopic condition. Okay. Also, finding other atopic disease in the child himself or in his family supports the diagnosis of asthma. Doing workup in the form of full blood count and finding eosinophilia usually supports the diagnosis. Not common and not routine and not necessary to do skin prick testing or IgE levels to diagnose asthma, but if present with positive results, this would support the diagnosis. So what happened? We have a genetic predisposition by certain HLA associations, and this genetic predisposition predisposes us to have atopy, to have immune response to certain triggers by increased IgE production, and on exposure to certain triggers like upper respiratory infections, like allergens, and like smoking, cold air, exercise, emotional upset, and chemical irritants, on exposure to these will result in bronchial inflammation, edema, excessive mucus production, infiltration with cells, including eosinophils, mast cell, neutrophil, and lymphocytes. This inflammation will end by bronchial hyperresponsiveness, which means we have excessive twitchiness or spasm to inhaled stimuli. Having this spasm will cause airway narrowing, and this narrowing is reversible, very important, and they have variability between day and night, okay, and from day to day, very, very important. So this narrowing is reversible with the use of bronchodilators, and this narrowing is variable with different with time of the day, diurnal variability, and from day to day and with exercise. This is very characteristic for asthma diagnosis. Symptoms in the form of wheeze, cough, breathlessness, and chest tightness. As workup, we do a chest x-ray. Chest x-ray is routine in the first visit for a child presenting with persistent symptoms like this, and it's not diagnostic for asthma. We use the x-ray to exclude asthma, having no positive changes appearing in the chest x-ray. However, hyperinflation can be seen, especially in case of acute presentation with airway obstruction. Seeing this by we having bilateral bilateral hyperinflation, very important, associated with increased bronchovascular markings. And you can see the widened intercostal spaces, the horizontal reps, okay, characteristic of the hyperinflation without any other pathology like pneumonia or bronchiectatic changes or other changes can be present. Scattered atelectasis can be present due to bronchial obstruction if it is severe. So we may have scattered whitish opacities, okay, due to atelectasis associated with more severe bronchial obstruction. Peak expiratory flow rate is a bedside test that is used for diagnosis and for monitoring the treatment in asthmatic patients. It needs a cooperative child who is more than 5 years old. It gives us indication of large airway obstruction. This is the tool. Please go to the YouTube and watch a video for its use when we ask the patient to inhale maximally, okay, in the start, and then use the mouthpiece of the device to exhale forcefully, as fast, as hard, as long as he can, to get this indicator of the amount and rate of air coming out of the chest, okay? It will be reduced in case of airway obstruction. So it gives us an indication of large airway obstruction. We used it initially for diagnosis, and then by the patient should be used every day and on exposure to conditions like exercise or stress, or if he feel any chest tightness or distress, he can use it to diagnose airway obstruction. Finding that we have day-to-day variabilities, that we have diurnal variability in the reading of the peak flow meter is diagnostic, and they can give us an idea about early changes of poor control in case of a patient on treatment. So early intervention with increasing the dose of medications or reviewing the action plan of the child can guard against progression of the disease. Okay, it can also grade the severity in case of acute episode of asthma attack. We will see later on. We use it to grade the severity between mild, moderate, severe, or life-threatening episode of asthma attack based on the reading of the peak flow meter. There is norms for the peak flow depending on the height and the sex of the child. Okay, and then putting a baseline for an individual and then following it every day can be beneficial in his action plan of treatment. So we have used the chest x-ray to exclude other diagnosis. We have used the peak flow meter for diagnosis and for monitoring. It is a bedside that is used by the patient himself. Another formal pulmonary function testing, which is the spirometry, can be used for initial assessment and then monitoring the progression and the response to treatment. This is spirometry. Also in a child who is older than 5 years old to cooperate with the test. We have discussed it, and we have found that we have obstructive pattern in the spirometry with a reduction in forced expiratory volume in the first second, and with reduction of the ratio between this and between the forced vital capacity, which is less than 80%, which means that less than 80% of the air inside the chest can be blown out by the patient during maximal expiration, after maximal inspiration. And this is an indicator of airway obstruction. Also, improvement of more than 12% after bronchodilator therapy indicate reversibility, and this is hallmark in diagnosis of asthma. Spirometry is used initially and used later on for monitoring of the control and to guide management plan. So what is the management of bronchial asthma? The management is based on two main lines, okay? To use anti-inflammatory line as it is a chronic inflammatory process that is not, if not treated, will result in airway remodeling that is not reversible, and with COPD or chronic obstructive pulmonary disease. Okay, so the first line is anti-inflammatory medication, usually in the form of inhaled corticosteroids, and the other line is bronchodilator therapy. Okay, which is reliever therapy to relieve the bronchospasm and so relieve the symptoms of chest tightness, of breathlessness, of cough, and so on. These medications can be delivered either via nebulizer, okay, which deliver just about 10 to 20% of the medication, or more peripherally to be delivered by the MDI or the meter dose inhaler. This is the MDI or meter dose inhaler, where we place here the medication vial, and by pressing okay, we deliver the medication here, okay, either to use it directly in the mouth, okay, by holding the mouthpiece in the mouth, but this need a cooperative child, okay, and it's preferably in children who are less than 5 or less than 7, okay, to use spacer, okay, and this spacer, a device formed of plastic, okay, where we join here the inhaler, and the medication is delivered, or aerosol is delivered here in the spacer, passing, and the child breathes via the mouth, through the mouthpiece, or via a mask. Okay, and when he breathes for about 10 seconds in this mask or from the spacer, this can increase the amount of medication delivered to the airways. This is very important. So MDI and the spacer is the ideal choice for delivery of the medication. 2 lines, bronchodilator or reliever therapy, and anti-inflammatory or preventer therapy. Reliever therapy, which means we relieve bronchospasm, we relieve symptoms. It's in the form of inhaled beta-2 agonist, in the form of salbutamol or terbutaline. These are short-acting beta-2 agonist, which has rapid onset of action within 10 minutes, and the short duration of actions, which about 2 hours, 2 to 4 hours. It's called relievers, and it's used as required. Okay, when the child is in attack now of bronchospasm, we use it whenever he feel symptoms of chest tightness. He use it for relief of his bronchospasm. In case of intermittent asthma, having symptoms on long distance basis, so we can just use the bronchodilator as needed to relieve symptoms. Okay, in case of acute episode, we can use high doses of these to relieve bronchospasm. So inhaled beta-2 agonist is a first line reliever therapy. Usually we found the inhalers in the blue color. Okay, the other one is the preventer therapy, and usually we educate the patient that your management plan is formed of 2 inhalers. One is blue and the other is pink, okay, which is the inhaled corticosteroid or the preventer therapy that is used as anti-inflammatory to treat the chronic inflammatory process. So inhaled corticosteroids is the most effective inhaled prophylactic therapy used on regular basis. Okay, it's not related to episodes. Every day we use inhaled corticosteroid to guard against frequent or severe episodes okay, of asthma, and also to relieve the chronic inflammation. And this will improve the quality of life, will improve the growth potential okay, of the patient. Very important. So this decrease airway inflammation and bronchial hyperreactivity. Can be used alone, okay, or in conjunction with other add-on therapy, as we will discuss, in the form of long-acting beta agonist or leukotriene receptor antagonist or montelukast. If used as inhaled modality with low doses, it has no clinical significant side effect of steroids. However, if used in high doses, high frequency doses, this can have systemic side effect in the form of impaired growth by affection of high velocity, and can be complicated by adrenal suppression and altered bone metabolism, and all side effect of prolonged steroid use. So we have bronchodilator therapy, we have inhaled corticosteroid therapy, and we have add-on therapy. When bronchodilator and low-dose inhaled corticosteroid is not um, sufficient to bring out proper control, we use add-on therapy. In the child who is more than 5 years, the first choice of add-on is the long-acting beta agonist. Long-acting beta agonist in the form of salmeterol or formoterol are effective. They have long duration of actions, 12 hours. So it is the first choice as add-on therapy if the child is more than 5 years. It is not used for acute asthma as we have delayed onset of action, and it should not be used without inhaled corticosteroid, and if proved not effective and give no response, it should be stopped immediately as it has side effects. Okay, it has cardiac side effects, so if no response, we should stop them. It proved very beneficial in case of exercise-induced asthma, and sometimes it used immunotherapy in these cases of symptoms that only is exercise-induced. Okay, so it can be delivered by different ways, use the inhalers or turbohalers or discus like that in older children. So add-on therapy in more than 5 years, the first choice is long-acting beta agonist or LABA, but in less than 5 years, LABA is not used, okay? And the alternative is oral leukotriene receptor antagonist, such as montelukast. These montelukast stabilize mast cell and reducing degranulation associated with increased IgE production. So this can relieve symptoms and can be used as monotherapy for asthma in children who are less than 5 years. Okay. In more than 12 years, okay, we have another add-on therapy, which is the slow release oral theophylline. Oral theophylline, as we all know, has side effects, okay, in the form of vomiting, insomnia, headaches, poor concentration, and have also narrow safety margin, can be complicated by cyanide toxicity. So it is not used in children, used in more than 12 years old patients, okay, and as if no response to other more safe medications. Guidelines are present to guard the diagnosis, the management of asthma, and it is based on a stepwise approach. It's called the step up and step down approach. When we assess the patient, we give the management plan that correlates to his present condition, and then we monitor him okay, over 2-week period to monitor the symptoms. If he is well controlled, we would consider to step down our medications after 3 months of good control. And if we found that symptoms are not well controlled, so we will go step up with our medications to reach the proper control. This stepwise approach or step up, step down approach, you should understand it, and very frequently you are asked about it in the exam. Starting with step 1, having intermittent asthma. We should categorize our asthma symptoms into intermittent or persistent. Having symptoms wide-based, okay, wide-spaced, okay, if the symptoms are wide-spaced and it is less than 1 day per week, so we have intermittent asthma, and in this case we use only the reliever therapy in the form of bronchodilator therapy or beta-2 agonist as needed. Okay, but when we find that we have persistent symptoms and we use the beta-2 agonist more than 1 day per week, when the child is awakened from sleep by symptoms, by cough or by wheeze more than 1 night per month, okay, when we have school absences, so it is a persistent asthma. And in this case, starting preventer therapy is essential in the form of inhaled corticosteroid therapy. So having infrequent viral wheezing and or no or few interval symptoms, we use step 1 management plan in the form of inhaled beta 2 agonist as needed. Having symptom pattern consistent with asthma and asthma symptoms not well controlled, or 3 or more of exacerbations per year, this necessitates starting the preventer therapy. One scenario in the exam giving you a child who has his second exacerbation or second episode of wheeze that necessitate PICU admission, and asking you if he would necessitate preventer therapy at discharge. So 3 or more necessitate starting preventer therapy, otherwise not. Okay. When symptom pattern not consistent with asthma but wheezing episodes occur frequently every 6 to 8 weeks, okay, this go to step 2 and start the preventer therapy. You can give diagnostic trial for 3 months. Okay, if we have response to the preventer therapy, so it is asthma. If not, search for other diagnosis. Okay, step 2 is formed of daily low dose inhaled corticosteroid. Okay, in children who are less than 5 years, we have an option in case of parents who are not likely to start the steroid therapy. It is one scenario in the exam. Mother refused to use a steroid, and the child is less than 5 years, so you have option to start a leukotriene receptor antagonist as a monotherapy rather than starting the low dose inhaled corticosteroid. Okay, so this is step 2 in case of children less than 5 years. Then reassess the condition after 2 weeks. Reassess the adherence to the treatment. Assess the inhaler skills. Assess the exposure, okay, to triggers. You should emphasize on avoidance of the trigger if it's known, okay, like cold air, like smoking, like pollens, like dust mites, and so on. So ensure that we have no exposures and we have adherence and we have proper inhaler skills. The use of inhaler is appropriate before considering to step up with the management plan. Okay, so if no response on step 2, you will go to step 3, okay, where you will increase the dose of inhaled corticosteroid, okay, and may use of leukotriene receptor antagonist if you don't have it used it in this step. Okay, if no response, okay, in a child who is less than 5 years, you will go up, okay, and refer him to a specialist. This is an indication if he is less than 5 years and no response to the doubling dose of low dose inhaled corticosteroids, so refer him for a specialist. If your child is more than 5 years old, okay, and you have passed through step 1 and step 2 and go to step 3, so first choice to use LABA or long-acting beta agonist besides the low-dose inhaled corticosteroid. Also, you may use the leukotriene receptor antagonist. Theophylline will be used in this step if your child is more than 12 years old. Okay, no response, and after ensuring proper technique of the inhaler and avoidance of exposure and the comorbidities like sinusitis and allergic rhinitis and so on, if nothing, so you should step up to step 4 and use the medium or high dose of inhaled corticosteroid beside long-acting beta agonist. And remember that you will stop long-acting beta agonist if proved not effective. Okay, step 5 is composed of the use of long-standing and the daily use of oral corticosteroid. Okay, this necessitates referral for respiratory specialist, is you will encounter side effects and you need to ensure the need for use of systemic steroids for long-term use of asthma. Other therapies also can be considered by the respiratory specialist in this case. This diagram from the illustrated pediatrics to show you the step-up, step-down approach, stepwise approach for the treatment of chronic asthma, starting with mild intermittent asthma. So in all ages, inhaled short-acting beta agonist is considered as required, but if it's persistent rather than intermittent asthma, so regular preventer therapy is needed. In all ages, inhaled corticosteroids in a dose of 200 microgram per day. If less than 5 years age, so consider the use of leukotriene receptor antagonist or LETRA as monotherapy, even before the use of inhaled corticosteroid. In adolescent and young adults, doses up to 400 is considered the low dose, can be used in this step, and monitor height and weight of all children on asthma treatment, very important, as long as they use corticosteroids. Step up if no control, okay, of symptoms within 2 weeks after ensuring the technique and comorbidities and adherence and so on. So step up and use step 3 and the form of add-on therapy. Add-on therapy in less than 5 years, we don't use LABA but use LETRA, okay, or increase the dose of inhaled corticosteroid to 400 microgram per day, the medium dose. Okay, if more than 5 years, okay, so consider the use of long-acting beta agonist, very important. If good response, so continue on LABA. If partial response, increase the dose of inhaled corticosteroid to 400 or even to 800 in case of adolescents. If poor response, stop LABA, very important, and increase the dose of inhaled corticosteroid. LETRA can be used, montelukast, okay, or slow release euphyllin can be used in case of adolescent more than 12 years old. Step 4, okay, if no response on step 3, so persistent poor control in less than 5 years, step 4, you need to refer to respiratory pediatrician. Okay, if more than 5 years, so you can increase the dose of inhaled corticosteroid to 800 microgram per day, and in adolescent increase the dose to 1,600 per day, and consider LETRA, and consider the slow release euphyllin for control. Step 5, so the continuous or frequent use of oral steroids. This necessitates respiratory specialist referral, very important. And more than 5 years old, maintain the inhaled corticosteroid at 800, so increase the dose. Use the lowest possible daily dose of oral steroid, maintain adequate control, and refer to respiratory pediatrician. And in adolescent and young adults, so use this dose of 1,600 and use the lowest possible dose of oral steroid, okay, to maintain adequate control and refer at this step. This was the pharmacological therapy, the use of preventer and reliever and add-on therapy in the management of asthma in a stepwise approach based on the initial condition and the follow-up, regular follow-up, very important. Non-pharmacological therapy or strategies include complete avoidance of allergen, but this can be difficult to achieve, especially if we don't know the trigger. And most studies of allergen avoidance have been disappointing. Okay, some children may get benefit from the use of dust mite impermeable mattress covers, okay, but most of children do not benefit from this. Allergen immunotherapy is effective as non-pharmacological strategy for treating atopic asthma due to single allergen. When the allergen is known, it is a single allergen, so we can use allergen immunotherapy. But its use is limited by risk of systemic allergic reaction on exposure to the allergen. Smoking should be stopped, okay, passive or active smoking. Exercise is encouraged. It improves the general fitness of the child. Psychological intervention as it is a chronic entity. Over 3 to 6 months follow-up, if control is complete. This considered when we have absence of daytime or nighttime symptoms, when we have no limitation on activities and no need for lever use, okay, in the form of bronchodilator, and normal lung function on spirometry testing, and no exacerbations, no need for hospitalization or oral steroid over 6 months period. So you consider your patient is well controlled, and you would consider to step down your management plan to reduce the dose of inhaled corticosteroid or to reduce the dose of montelukast and so on, okay? However, sometimes you fail to gain the proper control. And beyond step 5, you may resort to the allergen immunotherapy we have mentioned. Here they use the allergen to by certain technique. They form the allergoid, which will be injected, okay, as immunotherapy, and calculated small and slowly increasing the dose of the allergen injected to the patient, and usually done in the hospital to guard against systemic reactions that may occur and accompany the injections, with using increasing doses of the allergen. So differentiation of the immune cells, the naive T cells, into suppressive T cells can be beneficial and prove the promising effects, okay, in those patients. Other strategies may include continuous subcutaneous terbutaline, rarely indicated in the most severe cases. Anti-IgE monoclonal antibody omalizumab is one of the suggested therapies. Also, alternative immune suppressive drugs can be suggested in the most severe cases. This was the chronic asthma, the long-term use of chronic asthma, but when the child is presenting to in acute breathlessness. Acute breathlessness in child has differential diagnosis. It can be acute asthma episode, especially if he is previously diagnosed with asthma, but can be due to pneumonia or lower respiratory tract infection, can be a foreign body inhalation, can be due to anaphylaxis, okay, or can be a pneumothorax or pleural effusion. Look at this X-ray. We have here pneumothorax on the right side, having here the hyperinflation on the right side, and the collapsed lung tissue here, okay, and the homogeneous jet black opacity with no bronchovascular markings that appear here on the normal side. Pneumothorax can present as tension pneumothorax and present as acute breathlessness, and necessitate needle drainage, okay. Insertion of needle for drainage of the air can be life-saving, and it's a frequently asked question in the exam. So tension pneumothorax, okay. Metabolic acidosis in the cases of DKA and inborn error of metabolism can present with acute breathlessness. Severe anemia and anemic heart failure can be presentation. Heart failure also can be presenting with pulmonary edema and acute breathlessness. Panic attacks, okay, in the form of hyperventilation can be a differential diagnosis. So how to manage a case of acute asthma, acute episode of asthma? You need to assess the severity in the start. This diagram from Illustrated Pediatrics shows us how to assess severity of an episode of acute asthma into moderate, severe, or life-threatening episodes, assessing the ability of the patient to talk to you in sentences or in words. Assess his oxygen saturation by pulse oximetry. If it's more than 92%, so it's moderate episode. If use the peak flow meter, okay, and finding that the value is more than 50% of normal for age and height of the patient and his sex, so this is moderate episode, okay. And if respiratory rate is less than these values, and if heart rate is less than these values based on age of the child, so we consider this a moderate attack. When we have a child who is too breathless to talk, he cannot talk to you, okay, in complete sentences. He cannot drink, he cannot eat. His oxygen saturation is less than 92%. He has hypoxemia due to the severe airway obstruction. And if he can use the peak flow meter and find the value between 33 and 50%, okay, this is a severe attack of asthma. When we have respiratory rate higher than these values and heart rate is higher than these values, this is a severe episode of asthma, okay. A life-threatening episode of asthma should be considered when we have silent chest. We no more hear any air entry to the chest, and even wheeze disappear. When we have a cyanosed child, he has poor respiratory effort instead of being tachypneic and has retraction. Now the respiratory effort is poor. He is exhausted, okay, and exhaustion is the indication for intubation and mechanical ventilation in case of asthma. This is a question. Having arrhythmia and hypotension by the severe hypoxemia, and alter the consciousness, agitation or confusion. Peak flow by the peak flow meter is less than 33% of normal, and saturation less than 92%. Okay, this is life-threatening episode of asthma. Based on the assessment of severity, so your management plan will be, in case of moderate episodes, so keep calm and assure the patient and start to give him 2 lines of treatment, the reliever therapy in the form of beta-2 agonist, either via nebulizer or via MDI and spacer, plus the oral prednisolone and dose 1 to 2 milligram per kg. Okay, and then monitor the response after 15 to 30 minutes. If you still have symptom, you can repeat the beta-2 agonist. Okay, if you have a severe attack of asthma, so you need high flow oxygen. Okay, very important, and also start your 2 main lines with higher doses. Start the short-acting beta-2 agonist via the MDI with a spacer 10 puffs. Okay, or nebulized beta agonist in the form of salbutamol. Add to this the oral prednisolone also, or IV hydrocortisone can be used then. Consider use the ipratropium bromide or Atrovent, okay, besides the salbutamol for additional bronchodilation. And also consider the IV salbutamol, okay, or IV aminophylline or IV magnesium sulfate in this case of severe episode if not responding to the previous lines. In a life-threatening attack, so short-acting beta agonist inhalation should be continuous, plus the IV hydrocortisone, plus the nebulized ipratropium bromide. Consider the IV salbutamol, IV aminophylline, IV magnesium sulfate, and discuss referral of the patient to PQ. In a life-threatening attack of asthma, also consider the tenacious secretions. Usually those children have tenacious mucus, very thick mucus obstructing their airways, and relief of the condition would necessitate removal of these thick secretions, either by even up to intubation and suction, or manual removal of these secretions to relieve the bronchospasm. So if your patient is responding to the modalities of treatment, continue the bronchodilators every 4 hours and discharge him when stable on 4 hours, and continue the prednisolone for 3 to 7 days. Review with him the inhaler technique on discharge and give him a written action plan and arrange for follow-up visits. But if he is not responding, so transfer him to PICU. Ensure you have seen your medical review, and consider IV therapies in the form of IV magnesium sulfate, IV aminophylline, and IV salbutamol. Consider to do chest X-ray to exclude pneumothorax as a cause for the condition, and consider blood gas. Also consider need for mechanical ventilation in case of poor respiratory effort and imminent exhaustion and respiratory failure. Okay, this can be indication to start mechanical ventilation. Persistent cough, okay, has a differential diagnosis. Lastly, persistent cough can be bronchial asthma, okay, but can be other conditions like recurrent respiratory infection, like certain specific respiratory infection associated with prolonged cough, as pertussis that is associated with 3 months of cough after resolution of the infection. It's called the 100-day cough. Respiratory syncytial virus can be associated with prolonged cough even after resolution of the infection due to sensitization of the cough receptors. Mycoplasma also can be a cause for persistent chronic cough. Persistent lobar collapse following a pneumonia, maybe this is the lower lobar collapse, having this sharp demarcating line diagnose the lung collapse. This can be cause for the persistent cough and diagnosed by X-ray. Suppurative lung disease like cystic fibrosis, ciliary dyskinesia, immune deficiency, recurrent aspiration for whatever cause, persistent bacterial bronchitis need antibiotic treatment. Inhaled foreign body need extraction of the foreign body. Cigarette smoking, either active or passive, can be a cause, should be stopped before giving certain diagnosis. TB should be excluded and need high index of suspicion. Habitual cough, which disappears during sleep, can be a differential diagnosis. Airway anomalies like malicious and fistulas can be present as a cause for persistent cough. Thank you.